Hmm. Hmm. So very good evening, doctors. Yeah. So we are on live now, and very good evening to all. I'm Dr. Stalin on behalf of Shield Healthcare. Welcoming you all for the today's mixed bag webinar. I welcome the chief guest, Sampath Kumari ma'am, guest of honor, Dr. Ajay Singh Pardeshi sir, and conveners, chairpersons, and speakers for the day. And I would like to welcome the master of ceremony of today's session, Dr. Vestika Kishore ma'am, Madam was the past president, Mathura Obedience Society, member IAC Foxy 2122, advisor health, adolescent health, SMDHM, recipient of Foxy Wow Award for cervical cancer awareness in collaboration with Brahma Kumaris. And Madam is the chairperson of IMA Pink Health Mission Mathura branch, active involved in various school health programs, active Rotarian, and also her interest is high risk pregnancy, preventive oncology, and adolescent health. I welcome you, ma'am. I'm handing the session to you for taking it forward, ma'am. Welcome you.
Thank you, Dr. Stalin. Good evening, everyone. With the blessings of Almighty, we hereby begin our mixed bag webinar. Today, we have very esteemed faculty with us. Our chief guest, our dearest Dr. Sampath Kumari Madam, our guest of honor, respected Rajendra Pardesi Sir, Dr. Jyoti Sundaram Madam, our chairperson, Dr. Saroja Madam, Dr. Kalpana Madam, Dr. Vijayalakshmi Madam, Dr. Chandra Madam, Dr. Sarvana Kumar Sir, Dr. Swati Rathore Madam, and our conveners for today, our dynamic Dr. Ajay Manisher Sir, and another dynamic Dr. Pratibha Singh Madam. Now I request Dr. Ajay Manisher Sir to kindly introduce our chief guest and guest of honor and welcome them. Ajay Manisher Sir, please.
Thank you, Dr. Vartika ji. I'm very happy to take over from Vartika ji, the best MOC on this earth. Thank you very much. At the outset, I am very much obliged by the Sampath Kumari madam, who is my mentor from South India. Basically, I have got two mentors. One is Rajendra Singh Pardesi, and second is Sampath Kumari madam from South India. She is always a very humble, with such an academic and high attitude personality. She is so humble and down to earth person. I amaze many times how can a person will be such a simple personality. And saying at her, even she always, every time when she meets, she asks, how is your wife, how is your son? This is the attitude, man. This is because everything is apart. All the somebody said sampati is sampatti, she is wealth. She is a wealth of knowledge, she is a wealth of humanity. So I bow in front of her. So I welcome Sampath Kumari ma'am. And today I welcome all the dignitaries from Madurai, Dindigul, then Namakkal, Vellore, and Salem, and all the dignitaries from TNFOG. So to introduce Sampath Kumari ma'am, she is sorry, Foxy Vice President elect 2022, Founder Secretary TNFOG. She's a National Correspondent Editor Jogi 21 to 24. She's a Senate member Tamil Nadu, Dr. MGR University 21 to 24. She's a Chairperson Foxy Adolescent Health Education Committee 16 to 18. She's a Deputy Director and Professor OG, Retired Institute of Obstetrics and Gynecology, Madras Medical College, the great medical college from South India. Then President Board of Studies OG Tamil Nadu, Dr. MGR Medical University 15 to 19, member Board of Studies OG, Meenakshi Medical University, ICOG Governing Council member 15 to 20, then IMA Dr. Day Award, IMA Tamil Nadu State Branch, then she has got Foxy Dr. Duru Shah Distinguished Community Service Award, then Foxy Dr. Yane Pandit and Mrs. Shailaja Pandit Women's Empowerment Award, then Karmavir Chakra 15 National Award for Adolescent Committee Activities from ICO NGO, then written chapters in Foxy textbook, Foxy Focus newsletters. In my two newsletters also, she has given 2 chapters. So such a humble, great personality. I welcome and request you to kindly bless us, ma'am. Sampath Kumari, ma'am.
Thank you, Dr. Ajay, for the nice words. I have been to Dr. Ajay's house also to see the two cuties. Now they would have gone to the schools, and Rajendra Singh Pardesi, sir, he was the what to tell guide for me to start the TNFOG. Also, I got the opinions and discussions from Dr. Rajendra Singh Pardesi. It is my pleasure to be here on this evening for the wonderful webinar of mixed bags. I thank Dr. Pratibha, who has organized this webinar and honored me with great personalities like Dr. Rajendra Singh Pardesi, sir, and Dr. Ajay also. Okay, Ajay is going to become, and he is the West Zone president in the incoming years. And in this mixed bag webinars, as name suggests, Dr. Pratibha has included obstetric topic of preterm labor and gynae topic of endometriosis and the common infertility and the medical legal issues, with eminent speakers like Dr. Kalpana, Dr. Pratibha, and Dr. Ajay Manisher. That is also mixed from north, west, and south, with one senior chairpersons from Tamil Nadu TNFOG, like Dr. Jyoti from Madurai, Dr. Saroja from Dindigul, Dr. Vijay from Chennai, Dr. Chandra from Namakkal, Dr. Swati from Vellore, and Dr. Saravana Kumar from Salem. So it is really a mixed bag of speakers and chairpersons and the subjects. And my best wishes and all the best to the contestant, especially Dr. Pratibha and Dr. Ajay Manisher. And I wish the webinar a success. Thank you.
Thank you, madam. Thank you.
And MOC Dr. Vartika.
Thank you,
She is the
madam, for your
best
blessings.
MOC. Yes,
Yeah.
Ajay. Thank you, Ajay.
Yes, thank you,
Thank
madam.
you,
Thank you
madam.
for your
Thank you.
blessings. Now we move on to our guest of honor, who is another pillar of Foxy. One is Sampath Kumari madam, second is Rajendra Singh Pardesi sir, who is my mentor too. Dr. Rajendra Singh Pardesi, 27 papers presented, 20
It's
national,
okay,
7
Ajay, it's okay.
international.
It's
No,
okay, Ajay.
I need to read first two
Sir,
lines.
yeah, we should listen at least once.
Yeah. And he has got 6 times best paper awardee in Foxy AICOG conferences, highest award winner in Foxy. Nobody is of 6 times. Okay. He was faculty in AOFOG, then FIGO, AOFOG, then AOCOG, FIGO, and everywhere. He has presented so much of the seminars, webinars, and orations in front of me. I am seeing him since 22 years. And since then, he's doing his social work in his personal life and in Foxy also. He helped everybody. He is the person who has got no enemy in Foxy. He is
Yes.
such kind of person.
Yes.
Yes. So we present to Dr. Rajendra Singh Pardesi sir. I request you to kindly bless us. Pardesi sir.
His video has gone.
Must be a connection problem.
A connectivity problem, I think. Ajay, can you give a call to him?
Yeah, please. Just give me a minute. I'll call him.
Kalpana traveling,
சென்னை தான் சென்னைக்கு தான் வந்திருக்கேன் இந்த சன்னுக்கு பிராக்டிக்கல் எக்ஸாம்ஸ் அதனால
அப்படியா?
நாளைக்கு பிராக்டிக்கல் ஆரம்பிச்சது.
இன்னைக்கு நைட்டு நான் தங்குவேன். I'll give you a call to you.
Definitely.
ஆரம்பிச்சிடுறாங்க, எதற்கு தான் தங்குறேன்.
The internet is shifted.
Okay.
He is joining.
Yes. Kalpana, in the PCOS newsletter released by Dr. Shield, no, during Deepavali, and myself and Dr. Pratibha was there. That cover photos.
Okay.
Front page. From that time only, I knew Dr. Pratibha.
Now she is doing a lot of good work there.
Yes.
She is conducting quiz regularly, sending the prizes, and her prize is always a book, ma'am. That is appreciable.
Yeah, I always
She
give.
never gives trophy and money and everything. The book is given by her. That is the appreciable thing, basically.
No, Ajay, one of the newsletter released by the Shield people, that is near Deepavali. The front page photo is with the red sari. Me and
Yeah.
Dr. Pratibha.
Great, great thing.
Hello, am I
Yes,
audible?
sir. Welcome, welcome.
Yes, sir. Yes.
Thank you so much for inviting me and waiting for me. So it's a great pleasure and honor to be a part of this webinar with Dr. Sampath Kumari. As Dr. Ajay told, having Sampath of all knowledge and all. So I wish to congratulate all organizers for organizing this mixed bag very nicely, and just add to the biodata of our chief guest. Your chief guest is very uh, precious, and with Sampath, she is a hardcore organizer. I am telling you, she is Sampath Kumari ma'am is hardcore organizer. She is instrumental in forming TNFOG as a NGO, because many people they don't know, because the who has formed us, because it's not easy to form an NGO. There are too many hassles go in government agencies and all that. Nowadays we have to go personally to sign there, to collect their PAN cards, Aadhaar cards, to go there, and many documents. So congratulations, madam, and thank you. Thank you so much for gracing this occasion. And organizers also thank you. And this CME is very nice. The conveners, Dr. Ajay Mane, who is contesting for Vice President Foxy. I wish every success to Dr. Ajay Mane and also to Dr. Pratibha Singh for her chairperson for IAC committee. And these are the people Foxy needs, people like Dr. Pratibha Singh and Dr. Ajay Mane. In this CME, there is a mixed bag having ART and endometrium, medical legal tips from Ajay Mane and preterm labor with the faculties like Vijay Lakshmi, Chandra, Swati, Savarna, Jyoti, Saroja, Kalpana, and the most important MOC, Dr. Vartika. I wish every success to this webinar. And again, I don't want to be in between you and scientific content. My best wishes. Thank you. Thank you so much. Thank you.
Thank you. Thank you, sir.
Thank you. Thank you, sir. Thank you for the wishes. And over to you, Vartika ma'am.
Thank you, sir. So after our blessings from our seniors, we're about to start our first session for today evening, which is on ART and endometriosis. For this session, we have a chairperson, Dr. Jyoti Sundaram Madam. She is Professor, Department of Obs-Gynae, Madurai Medical College, and President of Madurai Obs-Gynae Society. She is member MTP Committee Foxy and an excellent undergrad and postgrad teacher. She has won many awards and she has got many publications to her credit. Welcome, Madam. Our next chairperson for today is Dr. Saroja Veluswamy, Madam. She is Secretary, Dindigal Society of Obs and Gynae. She has great passion for rural health care, and I welcome ma'am. Welcome, Dr. Saroja Madam and Dr. Jyoti Madam. Now I request Dr. Jyoti Sundaram Madam to please introduce our guest speaker, Dr. Kalpana Madam. Thank you, ma'am.
Thank you, Vetika. Thanks to Dr. Pratibha for involving our Madurai Obstetrics Society in this wonderful webinar. Dr. Kalpana, she is my very close friend. I was, closely associated with her for the past 20 years. She is MBBS, MDOG, and fellowship in National Board in Reproductive Medicine, PhD, FACOG, FAOG, and FACS. She is the senior most consultant in the Guru Hospital, Madurai. Her responsibilities being, she is the secretary of our Madurai Obstetrics Society, founder secretary of Madurai chapter of Topisar, national coordinator of Infertility Committee, Foxy, South Zone coordinator in Endometriosis Committee from 2014 to 2016, organizing secretary of MOX, Silver Jubilee Conference in 2018. She did a very grand manner in that conference. Course Director for Postdoctoral Fellowship in Endogynecology, member of Institutional Ethics and Principal Investigator in Clinical Trials. To her academic profile, she she had given many guest lectures in national as well as international conferences. She had organized many conferences and laparoscopic workshops till now. She had published more than 15 papers in national as well as in the international journals. To add to her credentials, she had got Best Doctor Award by Dr. MGR University, Golden Excellence International Award by European Continental University, Medical Excellence Award 2018 from the Government of Tamil Nadu, and the Best Medical Service Award from Madurai District Collector. These are only few. And Dr. Kalpana, she is going to talk on endometriosis and ART. Endometriosis is the primary cause of primary infertility in 6 to 10% of our primary infertility patients. In moderate to severe endometriosis, medical therapy is not at all effective in reducing the endometric cyst and adhesions. Hence, ART plays a major role, especially in recurrent and severe endometriosis. We are very eager to hear you, Kalpana. Over to you.
Thank you so much, madam, for your kind words. And you have told that our lovely friendship over 20 years. Thank you so much. First of all, I would like to thank Sampath madam and Pratibha madam for this wonderful opportunity. Let me share my screen. Can you see my slides?
Yes, Kalpana.
Thank you so much, ma'am. ART in endometriosis, when we think about endometriosis, even now, it remains an enigma. The symptoms of endometriosis actually do not correlate with the severity of the disease or stage of the disease. Actually, the incidence, as Jyoti madam exactly pointed out, in general population, it is almost 5%, but in infertile population, it is 10 times increased, almost 50%. Many a times patients come to us with the exact triad of symptoms like chronic pelvic pain, dysmenorrhea, and dyspareunia. But many a times we diagnose endometriosis by ultrasound, which has got a sensitivity and specificity of almost 90%. If a patient has got altered bowel symptoms, then transrectal ultrasound will be useful to diagnose bowel involvement in endometriosis. MRI is not routinely done in patients with endometriosis, but if a patient has got symptoms related to bowel involvement or bladder involvement, MRI is essential to come to a conclusion about the involvement of bladder and rectum. Ultimately, the gold standard for endometriosis is laparoscopy, because peritoneal endometriosis is not diagnosed by ultrasound or MRI. So the patient with minimal and mild endometriosis, many a times it is diagnosed only with laparoscopy. Laparoscopy is the gold standard for endometriosis, and if you suspect endometriosis in a patient, then plan for an operative laparoscopy and proceed. We're coming to endometriosis and infertility, we all know that normal couple has got a fecundity of almost 20%, but in endometriosis, it is 1 to 3%. And it again depends on the stage of the disease. How are we going to improve the fecundity rate in patients with the endometriosis? We have various treatment like IUI, IVF, out of which, how are we going to select select the treatment protocol for these patients. So medically assisted reproduction is defined as reproduction brought about through ovulation induction, controlled ovarian hyperstimulation, IUI, or ART. So when we think about IUI, it is definitely useful for patients with minimal and mild endometriosis. In moderate and severe endometriosis, ART is definitely needed, because when we think about the reason for infertility in patients with endometriosis, in severe endometriosis, it's very clear that it is due to tubal factor, altered tubo-ovarian relationship, and a defective ovum pickup by the tubes. But in minimal and mild endometriosis, various hypotheses have been put forward to explain the infertility in endometriosis. It could be due to salpingitis related tubal factor, or it could be due to, because endometriosis was considered as an inflammatory disease, various inflammatory markers like interleukin, macrophages are increased in the peritoneal fluids. So macrophages can cause phagocytosis of the sperms, or it can interfere with egg-sperm interaction. So it can be due to inflammatory etiology, or it can be immunological also. Many times the receptivity and implantation rate in endometriosis is significantly reduced. So various hypotheses have been put forward to explain the reduced fertility rate in minimal and mild endometriosis. So in minimal and mild endometriosis, COH and IUI will be definitely useful, because it was published in 1997 itself, where the author concluded that in treated patients with COH and IUI, live birth rate was 5 to 6 times higher compared to the non-treatment group. So it was again concluded in 1993, where 57 couples were included in that RCT with minimal and mild endometriosis, and pregnancy rate was 5 times higher. So it is very clear that in minimal and mild endometriosis, the pregnancy rates are significantly increased. Now, when do we go for IVF in patients with endometriosis? We all know that IVF is definitely needed when a patient has got tubal factor or male factor. Again, in severe endometriosis, if a patient is beyond 35 years with reduced ovarian reserve, no dilemma, the patient is for ART. But in minimal and mild endometriosis, if a patient has got very good ovarian reserve and less than 35 years, we can try few cycles of IUI. If she fails to conceive with the IUI, then she is a candidate for IVF. That has been published by Eshrey in 2005 guidelines itself. So what are the problems we are going to encounter when we have decided for ART in patients with endometriosis? Decreased oocyte yield is one of the most common problems we encounter when we plan for ART in patients with endometriosis. Decreased oocytes could be due to various reasons. First, the disease itself can damage ovarian tissue, so reserve is reduced in those patients. That could be a reason for poor folliculogenesis. Many times, these patients undergo repeated surgery. So with each surgery, the patient's reserve is reduced. So when we are planning for surgery, it should be planned properly. And the first surgery should be the perfect surgery without damaging ovarian tissue. So the other reason for reduced oocytes collected during oocyte retrieval is technical difficulty. Sometimes patients come to us with huge endometriotic cyst, and the follicles are actually behind the endometriotic cyst. Sometimes it may be difficult to reach the follicle, maybe because of greater cyst and sometimes due to adhesions. Because of these reasons, many a times we get less number of eggs in these patients. So when how to improve the number of oocytes in patients with endometriosis? In the market, we have n number of drugs which can really improve the ovarian response. But how are we going to choose the protocol for the patients with endometriosis? Kims et al. In 1996, in his RCT with 80 women, concluded that there is no difference in pregnancy rate in different protocols, maybe antagonist or long protocol in minimal and mild endometriosis. So in minimal and mild endometriosis, the protocol can be either antagonist, or which is commonly used for normal patients also, or long protocol. But in stage 3 and 4 endometriosis, ultra-long protocol is the best protocol, and it has been confirmed that in patients undergoing ultra-long protocol, the pregnancy rate is almost 50% compared to patients going for long protocol is almost 19%. So the mechanism, generally 3 shots of GnRH analogs given before starting stimulation. Sometimes nowadays, with the improvement in the vitrification techniques, we go for controlled ovarian stimulation and freeze the embryos and then give 3 shots of GnRH analogs, then plan for FET. So what is the mechanism by which GnRH analogs improve the implantation rate is GnRH analogs can modulate NK cells in the uterus, or it can modulate endometrial aromatase expression in the endometrium. So Salam et al. In 2006, this was a meta-analysis with 3 RCTs with 165 patients, concluded that GnRH analogs improve implantation rate and pregnancy rate in these patients. So in 2007, when antagonist was very popular, this author concluded that antagonist can also be used in patients with minimal and mild endometriosis without compromising the pregnancy rate or implantation rate. So even though we go for fine stimulation, we get reasonable number of eggs. The fertilization rate in endometriosis is also significantly reduced. That has been documented by Banhat et al. In 2002. So how are we going to manage this reduced fertilization rate? It has been proved that ICSI is always better than IVF to improve fertilization rate in patients with endometriosis. So what is the ultimate pregnancy rate in endometriosis patients? That has been published in 2001. It has been now documented very clearly that the pregnancy rate per cycle or per embryo transfer was almost similar in endometriosis patients compared to tubal factor. So this is a systematic review published in 2002. The author concluded that in this review, the pregnancy rate in stage 1 and 2 were not significantly different, but in pregnancy rate in stage 3 and 4 were significantly lower. The problem with this systematic review was the study period was between 1980 to 1999, and different drugs were used. There's no correction was made for medical treatment or surgical treatment. So this was the confounding factor in that review. So, but large database review from SART or Human Fertilization Embryology Authority concluded that in endometriosis, the pregnancy rate is not disturbed, is almost equivalent to tubal factor. So moving on to deep infiltrating endometriosis, what is the pregnancy rate in deep infiltrating endometriosis? We have conflicting results in that. So many a times we have a dilemma when we go for controlled ovarian stimulation. We all know that the estradiol level on the day of HCG is almost 4-5 times higher than natural cycle. So estradiol is the precipitating factor for endometriosis. So are we going to increase the recurrence rate in patients with endometriosis? This has been studied in 2011. The author concluded that gonadotropin ovarian stimulation was not associated with increased risk of recurrence. Again, when we are going for oocyte retrieval in these patients, antibiotic prophylaxis is needed for these patients to avoid pelvic abscess. So, as we have already discussed, Salametol concluded that Salametol and Cochrane review also concluded ultra-long protocol improves the pregnancy rate and live birth rate in these patients. So Cochrane review concluded laparoscopic aspiration or cystectomy in patients with endometriosis before ART will not improve the pregnancy rate. So when should we go for surgery in patients going for ART with endometriosis? If a patient has got severe pain, or if a patient has got a huge endometriotic cyst, which is actually hiding other follicles, then we have difficulty in accessing the follicles, then we need to go for surgery, but not routinely. So again, deep infiltrating endometriosis, if a patient has got severe symptoms, then we go for surgery before ART, but that is not going to improve the pregnancy rate, or actually it would reduce the ovarian reserve. It should be carefully done. So when a patient is going for extensive surgery, the options of oocyte cryopreservation and embryo cryopreservation should be given to those patients. So because ovarian reserve may reduce in these patients. So to conclude, endometriosis compromises fertility by several mechanisms. ART overcomes and achieves pregnancy except poor oocyte and embryo quality. Previously, endometrial receptivity, it was thought that endometrial receptivity was not altered, but recent papers have concluded that even in endometriosis, not only oocyte quality, but also endometrial receptivity is also altered. Surgery decreases ovarian reserve, so we have to plan it very carefully, and the surgery should be very appropriate and delicate. Only in symptomatic patients surgery is indicated. So perfect surgery may not compromise ovarian reserve. Results of ART are comparable to tubal factor and unexplained infertility. COH with IUI improves pregnancy rate compared to expectant treatment. IVF is more effective than repeated surgery or expected management. Thank you so much.
Thank you, madam. I request Dr. Saroja ma'am to say a few words.
Can you say that it is an excellent collaborate at the same time? It is a very difficult task to manage the ART and the endometriosis, and during traveling is also very difficult task. Just that we have to even ultrasound is enough to identify endometriosis, and COH and IUI for minimal and moderate and severe ART we should go, and IUI for IVF for tubal male factors, and severe endometriosis we have to go for, and control ovarian hyperstimulation in and IUI in mild and moderate. In when we go for IVF, definitely we go for long protocol. It will be very useful. Or COH can be done. We can freeze the embryo. The cryopreservation and oocyte will do well. Thank you once again, Kalpana, for giving this interesting lecture.
Thank you, Kalpana, madam. It was nice lecture. Very great. And
Thank
in spite of your busy schedule, you are in car. It's shows that.
Traveling is also a very difficult task.
Yes, yes. And in spite of that, she kept her word. Thank you. Thank you very much for your determination.
Thank you, Dr. Kalpana. It was wonderful.
Yes.
Thank you.
And thank you, Jyoti madam and Sarja madam. Over to you, Vartika madam.
Thank you, sir. Now, moving to our next session for today, Ask the Medical Legal Expert. We doctors may fall into any trouble anytime during our practice. So once we fall into trouble, that trouble will go like a bubble if we have experts like Dr. Ajay Manisher. So to chair this session, we have Dr. Vijay Lakshmi madam. She is former professor of Gynae, KV Medical College and Research Institute and Meenakshi Medical College and Research Institute. She is executive committee member, OGSSI, and honorary treasurer, TN Fog 2021. Welcome, madam. Our second chairperson for this session is Dr. Chandra Ponuswamy, madam.
Hello, Vartika ma'am.
Hello, Vartika.
I think the net connection. I'll read the biodata.
Am I audible?
Yes,
Yeah, please.
Yes.
So, ma'am has been the past vice president of NAMCAL IMA and founder secretary, Women Doctors Association NAMCAL, and she has delivered first IVF and first ICSI baby. Welcome, madam. Now I request Dr. Vijay Lakshmi, madam, to introduce Dr. Ajay Manisher, though he requires no introduction.
That's correct. Very good evening to one and all. I'm extremely thankful to Dr. Sampath Kumari Madam and Dr. Pratibha for giving us this opportunity. On behalf of my co-chair also, I'm saying this. Thank you all so much. It's really a privilege to introduce Dr. Ajay Mane, who really needs no introduction. Medical legal consultants in India are very few and we all rely on you so much, sir. Sir has been a member of the NIMC, National Inspection and Monitoring Committee, Government of India through FOGSI. Medical legal consultant since 18 years for free of cost. That's most important. He's been chairperson, official MOG's website, chairperson, Sexual Medicine Committee 2014-16, chairperson, Adolescent Health Committee, and past president of Aurangabad OB-GYN Society. He's ex-superintendent of MGM Medical College, Aurangabad, trainer for FOGSI Adolescent Health Committee, health advisor and Sports Authority of India, Aurangabad, and charter president, Rotary Club of Aurangabad Elite. Welcome, Ajay Mane, sir. I don't want to stand between you and the audience. Please go ahead, sir. Thank you so much.
Thank you, Vijay Lakshmi madam. You all are such a stalwart and senior people. I'm very much obliged by your presence and your acceptance of our invitation by my and Dr. Pratibha ma'am. Thank you very much. So today we have changed the topic somehow. It is like, okay. The topic will be Ask the Medical Legal Expert in Day-to-Day Obstetric Practice. Is it seen and heard?
Yes.
Yes. Some of the questions reached me and some are the very common questions asked by all the delegates and everybody. So I incorporated those questions and tried to give answers. And in spite of this PPT, anybody can ask anything about medical legal things. Okay, we'll go. I'll be very fast in the slides. There are few situations given. Patient came with a pregnancy of 17 weeks for first time and her age is 17 years. For first time is very important. Huh? Okay, here. And 17 years, what next? So in such situation, if you indulge in practice that such patient come to you, then first and the foremost thing is that POCSO Act applies here. What is the POCSO? Protection of Child from Sexual Offences. This is the act formed in 2012, amended in 2019, and very strictly applied and amended, applied in India. So under this POCSO Act, we are bound to inform police or the child welfare committee, most of the time the nearby police station, in written format, whenever we come across a patient who is pregnant less than 18 years. That is the sentence. Married, unmarried does not make any difference. Though she is married, you must inform the police. See, there are many laws which are indulged in this. The law of rape is indulged because the definition of rape, what does it say? It says a unwilling full sexual act, penetrative, non-penetrative, only touching also. New definition of rape is very broad. Complete paragraph is there. Less than 18 years. More than 18 years without consent, and less than 18 years with consent also, if she is a unmarried. If she is a married, then less than 16 years without consent or with consent, it is a rape. But if she is married between 16 to 18, it is not a rape. It was the previous rape definition. Now they have changed. Less than 18 years with or without consent is a rape. So it becomes a rape. So it becomes also a POXO Act provision. So if she is less than 18 years and pregnant, you need to inform the police. 17 weeks is no, it can be 6 weeks, 12 weeks, 22 weeks, whatever. But POXO Act apply here. Follow the protocol. What is the protocol? You need to inform the police in a written format, have a received copy, because the police may deny afterwards if something goes wrong. Somebody posts you in the case that Dr. Mane did not inform the police. So the court will summon me. I have to go to police station and the court, and they ask you, did you inform? Yes, sir, I have informed. In what format? I have phone called them. Okay, what is the proof? No proof. So we are at problem. So kindly inform them in a written form and have received from them. Most of the time, they don't give you received. This is the situation we have seen in many cases. If they do not give on insisting also, then send this copy to the superintendent of the police or the in charge of that police station, maybe DYSP, SP, and get from that office. But your received copy is must for your safety. That is the point I wanted to tell you in this situation. Okay. And documentation, keep that record with you and go for whatever you want to. The patient is 17 years, and if he wants MTP to be done, the MTP can be done with the permission of the, or rather the signature of the guardian, not legal guardian. The guardian means whosoever is accompanying the patient can be a guardian, maybe father, mother, or friend, or a boyfriend, whatever, who must be above 18 years. Then and then only that consent is valid. 17 years, so the patient consent, patient signature on consent is not accepted. More than 18 years fellow can sign the consent. Okay, that is the point. Clear? Second situation. Sorry, unregistered patient came in early labor, not ready for any investigations, and asked for admission and delivery. Can we deny? Yes. Denial of a patient is a right of all doctors, except in one condition. And what is that? Life-threatening condition. So you are gynecologist, and very nearby to your hospital, there are one incidence of accident, and the people, they take the patient to your hospital. Sir or madam, see, he is bleeding or she is bleeding. Then you cannot deny. You must go for the first aid purposes, all compressive bandages, trying to stop the bleeding, start IV line, call the ambulance, put the patient in ambulance, and refer to the appropriate center. That's all. That is your duty. That is bound to be your duty by the law and by the Supreme Court verdict. We have to follow the instructions. So only and only first aid is to be done. Though you are not expert in that, we are not orthopedic surgeon, we are not surgeon, but we can have a dressing and we can stop the bleeding, we can put the IV line, we can send the patient. That's what. But if in such this situation, unregistered patient come in early labor, so there is plenty of time. It is not emergency, it is not in hurry, so we can deny the patient. Okay, send with the proper documentation, referral letter. See, unregistered patient, we don't accept unregistered patient, and she is not ready for investigation, so we are sending the patient to, and send the patient to the government hospital. Okay, because not a single private hospital will accept in such situation, not ready for any investigation. Sorry. So proper documentation, consent of the patient, and if something goes wrong, patient won't produce that referral letter which you give to the another situation. Okay. Next situation. Registered patient with routine follow-up came at full term in labor and insisting for normal delivery only and not ready for cesarean section if needed, as the fetal heart rate is fluctuating, maybe less than 120, maybe more than 160 or whatnot, and decelerations and early and whatnot. Okay. Then what? Record proper findings of that NST and partogram. Partogram is very important situation in this condition because in one go we can have the dilatation, the descent of the head, the cervix, the condition, the liquor, the baby, the mother, blood pressure, everything we can have in one go, and this is a legal document. Only medical colleges and big institutions, they maintain the partogram, but it is very important to maintain the partogram in each and every hospital. It is very simple. It is very simple. So please follow that. And if you maintain the partogram, you need not maintain other records also, because it gives everything on one paper with the time, and all the readings are there. So partogram is a legal document. So maintain partogram. Fetal record, CTG records. Then negative consent. What is negative consent? If patient is giving positive, yes, that is positive consent. And if patient is saying, no, 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 I'm not giving you consent, so take the consent that in spite of doctors telling me all the conditions, all the adverse results and all the outputs, I am not ready for the cesarean section. Take a signature, take a left thumb impression with the signature, because patient always denies that this signature do not belong to me, and doctor has forgery, and the sister has signed, or the doctor has signed, and I have not signed. It happens, and we have seen thousands of cases in court of law. The patient denies there straight away. So have a left thumb impression. They cannot deny the left thumb impression. We can go to court of law and ask them to kindly verify, because in 10 lakh people, one thumb impression matches to other. It is very much almost impossible thing to match one thumb impression with the another person. So have a thumb impression. And one more thing, ask them to write their name below the signature in their own handwriting. Mind it? Why? Because they cannot deny again the handwriting. They can deny the signature, but they cannot. We can send the paper to the handwriting expert through court, and the handwriting expert will say, yes, the handwriting belong to this fellow, so the signature is also belong to this fellow. That's all. We are safe. So always think of your safety first and then patient. Not that you think of safety of the patient first and then you. No, you are important. Fine. Okay. And I have not helped a single patient in last 18 to 19 years. I have helped all doctors. Okay. Patient were ready to pay me lakh rupees, but I didn't help them. And with God's grace, I'm Sampath by nature. Okay. So the blessings of Sampath Kumari Madam. Negative consent is that. And refer with all protocols that I told you. Referral letter, everything. Again, next situation. Patient not progressing well in labor and not ready for cesarean section and not ready to shift to another hospital. That is again next situation. What steps will you take? Patient is not giving negative consent. Patient is not ready for the cesarean section. Patient is not ready to get shifted. Then what you will do? So again, all records. What records? Negative consent. And if patient denies for the negative consent, take a patient who is on the second bed or the relative of the second bed patient, that this doctor has explained each and everything to this patient in front of me, and the patient denied for the consent and for the negative consent, and take the signature of that fellow. That will be safer for you. Okay, that is a situation. Okay, then if patient is not ready to shift, then explain each and every output, then denial and shifting of negative consent. Second opinion, take second opinion of your senior, maybe a junior, maybe your colleague. Call, get it written on the paper, that same situation, because two experts, if they matches, the court always accept that this is true. That's why take a second opinion. Second opinion is very important. And whenever somebody calls you or some your colleagues calls you for the second opinion, please go and help that, because that condition may arise at your hospital. Okay. Next situation, hand prolapse. Patient come with hand prolapse in labor. What is next step regarding documentation? I'm not going for the orthopedic details, that brachial plexus injury and all not whatnot. Okay. Documentation. Counsel about consequences and document it. What can be the consequences, the policies and all the things, everything is explained, and write it down. because see, patient is in labor, so patient cannot give the consent or the yes, I have been explained everything, signature on that document. So take patient's near relatives consent on that. Okay, because that consent in that situation patient cannot give, and if she gives, it is invalid. So in labor you cannot take the consent. So before labor it is okay, or between the pains it is okay if she is settled, not in hand prolapse. Then signature of witness. This has been explained in front of me. There are two situations. See, one are good educated people who can read and who can write. The second thing, whether the consent form must be in English format or a vernacular medium. Maybe in English or maybe in vernacular. Vernacular is always better because the local people may read and understand that. If it is not available, then you can read in English, explain it in their own language, and after that completion of your consent reading, explaining, write down one sentence that this consent has been explained to the patient and the relatives in their own language or the vernacular language. See, third condition is that if you don't know their language, then have a translator with you. Then ask the translator to translate and explain everything. Get the translator signature on that consent form. These all are the consent situations. One, you explain. Second, the patient must be having a signature. Two signs are important: doctor's signature and patient signature. Then and then only it is complete document. Any signature is missing, patient has signed and doctor has not signed, it is incomplete document. So these both signatures are must. Then third signature of witness, that the patient has signed in front of me. The witness signature is nowhere related with the treatment part. What it says, the witness says this signature has been done in front of me. That's all. And the fourth one, if translator is needed, then have a signature of the translator on that consent. Finish? Okay, right. Consent for procedure, everything. Pediatrician must be present during procedure. Nowadays, everybody is having pediatrician for normal delivery also, because the basically responsibility is shared. And second thing, you are safe by law. You have taken an official opinion of an expert who is expert field in that pediatric field. So pediatrician's opinion must be there. He must write his notes on your indoor paper every time. And here it is very much needed. Take proper consultation of other attended to orthopedic surgeon, neurologist, maybe if needed. Cord prolapse. Patient come with a cord prolapse in labor. What is next step regarding documentation? Same thing, only hand is cord is replaced by hand. The cord prolapse. क्या हो सकता है इसमें? So everything can go wrong. So counsel about consequences and document it. Death, demise, everything, asphyxia, Down syndrome, everything. Then signature of witness, as I told you, consent for procedures, because you need to have emergency cesarean section. Then pediatrician must be present during procedure. Keep all records. You need to have a assistant who is putting the cord prolapse, the loops inside, and putting hand there with the soiled gauze piece and shifting to OT. This has to be written on the paper. We have taken care of the cord during shifting the patient to the operation theater, and till that moment the baby is taken out from the cesarean, the hand is put there. Likewise, you need to mention each and every act of yours must be written on the paper. Then and then only it is considered that you have done. If you do not write any single step over there, or you miss the step to write down there, it is considered that you have not followed this. Likewise, so please remember everything and write it down sequentially. Okay, if you want to scratch something, just put a single line on that and rewrite the line below. Don't overwrite. Okay, and it must be readable. And refer baby immediately to NICU if needed with the pediatrician. Then next situation, IUFD, intrauterine fetal demise. Document patient's non-compliance in the outpatient record. Patient has not come to you. Say for an example, G4P3L0.
Sir, Ajay sir, sorry to interrupt. A little loudly, please, sir.
Little louder.
Yeah, now it's correct.
Okay, madam. Okay.
Thank you, sir.
Thank you. IUFD, primary with severe PIH, present at 39 weeks with IUFD on admission. So what you must mention on the paper: did not come for checkup as advised, documented. Did not get blood pressure checked regularly, documented. Did not take treatment as advised, documented. did not maintain fetal movement count as advised, document it. Why? This documentation will help you as it becomes a contributory negligence on the part of patient. What is a contributory? What is negligence? Negligence is done by the doctors. Whatever they are bound to do, they have not done, is a negligence on the doctor's part. But whatever is bound for the patient to follow the instructions, if they have not done and the adverse results are there, then it becomes a contributory negligence, and contributory negligence is very much beneficiary for the doctors, because something goes wrong, we are not responsible and the patient is responsible. We can prove it. That's why this documentation is very important. Patient is not following your instruction, write it down on paper. Patient not following instruction, patient not taking tablet, patient not coming for the regular follow-up, or patient not giving proper information to us. Likewise, everything that simple one sentence or two sentence may save you in the court of law. Okay. Situation. Patient is in PPH and you have not done the blood grouping prior, as patient was your regular one in ANC. This is negligence. Because many times it happens that actually we are not at fault, our staff is at fault, but ultimately we are responsible for that. That is a vicarious liability, and it is a liability of our as a doctor. Is it negligence? Yes, it is negligence. Civil or criminal negligence? It is a civil negligence if patient is saved. If patient is in severe PPH and succumbs, then it becomes a criminal negligence, because not having a blood group in regular ANC can be a fatal condition. To have a blood group takes at least 15 to 20 minutes, and the rate is 300 ml per minute. So 10 to 15 minutes means 4.5 liters. Then that will end the patient. Likewise, if it is a severe PPH, 300 ml per minute is the rate of flow in the PPH, severe PPH. So it is a criminal negligence. If patient goes, it is correct. And in civil negligence, you need to pay the compensation. But in criminal negligence, you need to pay the compensation as well as you can have the imprisonment also. Likewise, and compensation, how many years she must have earned into the 60 up to 60 years minus 35 years means to 25 years she must have earned into 1 month's income, tentative into 12 months. Likewise, it goes in crores. Then next question, do we need to change our MTP registration certificate from approved authority as changed from 20 weeks to 24 weeks? Nowadays, recent amendment 2nd of October, there is no need to change the certificate. Certificate A is application, B is your certificate, which is displayed on your notice board or at your certificate line, the MTP registration certificate. There is no need to change, as government said that 24 weeks word must be replaced at the 20 weeks. So it is a replacement. No need to change the certificate. But some appropriate authorities at the district level, they are asking for submission of the old certificate and getting the new one, where it is mentioned that up to 24 weeks. If it is there, it is okay, but it is a free of cost service by the government. No fees is to be paid. If somebody asks, ask them in writing, ki iska fees ka hai, so give me the receipt. Nobody will give you. Okay. This is the answer. Next question. Can we terminate pregnancy after 24 weeks and after 20 weeks? Yes. Now the permission for the termination of pregnancy is extended from 20 weeks to 24 weeks. Up to 20 weeks previously, up to 12 weeks, there must be opinion of one doctor, and 12 to 20 weeks, there must be opinion of two doctors. It was previous. In amended law, up to 20 weeks, opinion of one doctor only, and 20 to 24 weeks, opinion of two doctors we need. And above 24 weeks, if some patient comes 25 weeks and needs termination, then there is a medical board at all district levels. We need to send the patient to medical board. Medical board needs to send the report yes or no in 3 days, and we need to terminate the patient within 5 days. So within 8 days, the patient is free if indicated properly. After 20 weeks, there are only and only congenital anomaly conditions or some social conditions. Marriage is broken, rape cases are there, minor girls with the rape and all the things, they can be terminated up to 24 weeks. But the rape case beyond 24 weeks is not allowed. It must go to court, not in front of board. That is the only situation where we need to go to court. Okay, fine. I told you. Is failure of contraception available after 20 weeks, up to 24 weeks? No. Failure of contraception is the fifth indication of termination of pregnancy, which is given in form opinion form. But previously, it was available only for the married woman. But in amendment, they have made it available for the unmarried woman too. Okay, so unmarried woman can nowadays we can write in unmarried girls or women that failure of contraception, but up to 20 weeks. After 20 weeks, it is not allowed. After 20 weeks, it is allowed. I have told you in form E, it is given. What is the next? In case of USG performer is different. Can a owner of USG center sign the report? In Supreme Court, in one case, exceptional case, they have given that the doctor was in hurry and went for emergency situation. The owner of the hospital or the sonography center can sign, but it is in exceptional situation. Regularly, it is not allowed. The doctor who is performing the sonography must sign the report. Okay. Is USG mandatory before MTP? No. By law, it is not mandatory, but by my opinion, it is must be done. Why? It tells about two things. One, whether it is intrauterine or extrauterine pregnancy, whether it is intrauterine or heterotropic pregnancy or tubal pregnancy, whatever. First, because I have seen so many cases that medical termination of pregnancy method followed, tablets given, and the tubal ectopic rupture. Why? Because we do not know the pregnancy is in tube or whatnot. Because every time the cervical movements or the fornices are not tender, unless and until it is stretched. If it is not stretched, it is not tender. We have seen so many cases. First thing. Second thing, it tells about the gestational age. Say for an example, you are having first trimester abortion center, 12 weeks, and the patient come to you and says that it is 11 weeks. She tells you false dates. And see, clinically, you cannot judge 11, 12, 13 weeks. It is on a borderline. So after that, if it is proved to be 13 weeks and 14 weeks, you are at problem. So have a sonography, get a proper gestational age, get a proper site of the pregnancy, and then terminate it by proper method. Fine. Next question. Is it mandatory to mention missed abortion, incomplete abortion, inevitable abortion, and blighted ovum in MTP record? No. They do not come under purview of MTP. So they are to be mentioned in obstetric complication registered and indoor paper. They do not come under MTP. So no need to fill the form 1, form C, and mind it, for all MTPs, medical line and surgical line, all MTPs need to have a separate consent which is designed in form C. You can have another format of consent along with that, but the form C is mandatory. Okay, it must be there. If it is not there, you are at fault. Fine. Finish. No. Okay. Which are the documents in PCP? It is very long question. C form A, B, C, D, E, F, G, H. A is application. B is certificate issued by the approved authority. C is denial. If they reason refuse your application, then what may be the reason? They have given in form C. Form D, genetic counseling center. Form E, genetic laboratory. Genetic counseling center means all ART centers, and form E, genetic laboratory means where the chromosomes are treated. Likewise, that is genetic laboratory. We don't have that. Banks and all the things. Form F is online F form. We know A, B, C, D, all four parts. A is information, B is non-invasive, C is invasive, and D is declaration by doctor and patient. Form G is consent for invasive procedure. Say for an example, amniotic fluid is being taken out for the chromosomal abnormality, or placental part is taken out, whatever. Form G is to be filled. And Form H by authorities. All information is put in one format, that is Form H. Tell in detail about Form F in PCP and DT. So it is very difficult, very vast. I told you 4 sections, A, B, C, D. Amendment, how to scrap old machines. That is again an important question. Amendment in 2003, amendment in 2003. Machines, abandoned machines must be handed over to the approved authority with received from the purpose of condemnation and scrapping. Okay, you hand it over to the approved authority. That is their headache, how to scrap it. But at all district level, they have formed one committee under the presidency or the chairmanship of either civil surgeon or in Tamil Nadu they are called as deputy director, I think, or joint joint director. JD, no?
Yes. JD.
Yeah, JD under chairmanship of JD. They have formed one committee at all district levels, and they scrap the machine. Your duty is to hand over machine to them and have a receipt from them. That's all. You are free. Because if the machine is kept with you, though it is sealed, you need to submit the record as a zero sonography done. It was very tedious thing. So we followed this thing through Foxy to a government level, and we sanctioned this. They need to, and amendment in 2019, they have to form the committee. Okay. What are the penalties under violation of PCPNDT Act? You know all the act. I'll explain the meaning of these three words. That is important. Cognizable, non-bailable, and non-compoundable. What is a cognizable? The police can take cognizance, and the investigating officer, police inspector or the sub inspector, he or she can start the investigation on their own without the order of court or the summon. On their own, they can start. That is very troublesome for us. The police may come and they can trouble you a lot. Okay, that is a cognizable. MTP and PCP both are cognizable. Non-bailable. In non-bailable, you get bail through court only. In bailable, you get the bail at chowki, police chowki. They will get it written from you that in such and such conditions you are on bail and you need to go to the court at certain period and you get the bail. That is a bailable. But if it is non-bailable, police may take you, may not. Police take you and put you behind bar. Till that moment, they produce you in front of the magistrate, and the magistrate grants the bail if it is a grantable. If it is a very severe negligence, they may not grant the bail, and they may extend it for 2, 3, 4 days, and you need to be there behind bar. It is very troublesome situation. That is a non-bailable. And third condition is non-compoundable. What is non-compoundable? Once a case is filed in the court, it is not taken back. So see, I have got a case against Pratibha ma'am, and if we compromise, both of us, we can give the application to the magistrate that we have compromised and we are taking back the case. The magistrate allows. That is a compoundable. But in PCP, in MTP, it is a Dr. Ajay Manisher versus State of Maharashtra, the Dr. Pratibha Singh versus State of Tamil Nadu. Likewise, it is there. And once a case is filed, it is not to be taken back, not allowed. That is a non-compoundable. So it has to be till the end. This is the fate of the case. Okay. And the fines, you know, basically 1,000 to 5 lakh, and the imprisonment for up to 7 years. The difference between PCP and MTP. One consultant may have many centers in MTP, not in PCP, only 2 centers in one district. If you are residing in a border, so you can have another 2 in next district. But the condition is that you need to give a timetable at every sonography center that 2 to 4 Dr. Ajay Manisher is available here, 5 to 7 Dr. Ajay Manisher is available there, and likewise you need to be there. 2 to 4 is written and you are available since 1 o'clock. It is not accepted. Okay. So 2 centers in PCPNDT, many centers in MTP. I can go to any place in India for MTP as I am recognized MTP performer, and the center is recognized, patient is clear recognized. No regular inspection mentioned in law for MTP, which is there for PCPNDT every 3 months. No renewal for MTP, which is there for PCPNDT every 5 years. Place approved and not restriction for persons, that is MTP, PCPNDT, where my name is written on the certificate, there and there only I can go and perform sonography. But for MTP, it is not like that. I can go to Pratibha Singh's madam, or I can come to any center, Sampath Kumari madam center in Tamil Nadu and perform MTP. But if I change the state, I need to inform the state appropriate authority once. That's all. It is non-bailable, cognizable, non-compliant, rigorous imprisonment to 2 to 7 years and fine for MTP and 2 years for PCP. So we are at the end of the presentation. So anticipate the situation. So proper documentation needed. Keep blood ready in cross match, especially with RH negative. Documentation about followed all protocols. ICOG, Foxy, ACOG, WHO, RCOG, all protocols, because these protocols are there to save you. If you produce the protocols in court of law that, see, this is my procedure done by paper, and this is the protocols, you are saved. Court says, okay, everything is followed. Okay, fate is not in your hand. The fate is, whatever the fate is, you are not negligent. If you have followed the steps, you are not negligent. That's all. Done everything according to the present situation and in anticipation to all consents with proper procedure and legitimate record. Okay. What is the take home message? Follow all protocols, document, keep trained staff, training and drills regularly. because something goes wrong, you patient come with a PPH or patient lands in a PPH, your staff start running. Ye kidhar hai, wo kidhar hai? I don't know, ma'am. I am new. I have not kept it here. Likewise, so regular drills will accustom them or make them trained to have such situations. Have a system in hospital working pattern. Keep good relation with your colleague and help them when needed. Okay. So thank you very much. Gratitude to Sampat Kumari madam and Rajan Singh Pardesh sir for accepting our invitation. And Dr. Jyoti Sundaram madam, Dr. Saraju Veluswamy madam, Dr. Vijaya Lakshmi Gnanasekharan madam, Dr. Chandra Panuswamy madam, Dr. Swati Rathod madam, and Dr. Sarvana Kumar sir for being there and blessing us. Then the speaker, Dr. Kalpana Balamurgan madam and Pratibha Singh ma'am. TNFOG, Dindigul, Namakkal, Madurai, Vellore, Salim Ubja Society. I request you to kindly nominate both of us. If you have not nominated till it is still the date is there till 14th midnight. Kindly nominate and kindly vote for us. Thank you for giving chance. Then Dr. Vartika Kishore ma'am as MOC and Mathura Society, all delegates. And most important is Dr. Stalin from Shield Healthcare, who has given the academic support to all of us. If needed, I am always there. My phone number is always there. My mail is always there. And it is completely free of cost. Since 18 years, I am doing this only for doctors. You can have a photograph of this slide and you can call me anytime. Because a few days back, 15 days back, some doctor from Hosur called me and I have helped her. I could not disclose the name, but I have helped. So I was not knowing that she may call, but that was my help. With God's grace, I could help her. Thank you, God, and thank you all. This is woman empowerment. She is carrying. Woman is always a mother for whole life. She is a symbol of love and carrying a gun for the protection. And this is a woman empowerment in India. She is carrying a gun for nation and carrying a stethoscope for the colleagues. See that China Glacier, Dr. Captain Deepashika Chatri. I salute the woman and salute the greatest army of the world. And I salute these fellows, the lowermost chain of the health service in India. See in which condition they are going and vaccinating. So it is a 150 crore janta, 160 crore janta we have vaccinated. See the situation. She is sitting in a Kutch run, 5-6 months old baby, vaccine carrier, husband, the kids, and she is performing the duties. Great woman. I salute these women. And I salute all the women basically, because you are a symbol of determination. So this is my again a humble request to kindly vote for me. Those who have not nominated, kindly nominate both of us. And thank you very much. Help your colleagues. Thank you.
Thank you, sir, for that wonderful lecture. I request Dr. Chandra Panuswamy madam to say a few words. Dr. Chandra madam.
Yeah, good evening, everyone. At the outset, I would like to
yes.
thank you, the conveners, Dr. Ajay and Dr. Pratibha, for including me and our society in this wonderful webinar. And it was a really wonderful speech by Dr. Ajay. He has given every detail what we will come across during our day-to-day practice. And so now we are clear, and everybody, I think all the delegates, they will be having, and I wish you both success in your contest, and I will see you next as chair and vice president.
Thank you.
Thank you, madam. Thank you very much. We need your
Chandra, have you
blessings.
nominated Dr. Ajay?
Yes, finished.
Thank you, madam. Thank you very much.
We have done it. We have done it.
Yes.
Thank you.
Me.
Thank you, madam.
Best wishes
Thank you.
both of you, and thank you very much.
Thank you, madam. Thank you very much.
Thank you, Vijay. Thank you.
So,
Thank
any
you.
question? Any question from anybody?
Sir, I myself have a question.
Yeah.
In our side, one particular community, they get married before 18 years.
That is very difficult.
Yeah, then if they come for regular checkup with the family, with the husband, everybody, if you send them to police and all, it's very difficult for us.
Yes,
no?
yes, I know, madam. This is the same situation in Maharashtra also. In rural Maharashtra, we got tradition of having girls married less than 18 years. Then it becomes very difficult situation. We urge the government that you should keep the limit of 16 to 18 for married girls. likewise, but they are thinking on that. But till today, it is not done. So we need to inform police if it is less than 18 years, though married, though unmarried.
So,
Or second option is there. It is very unofficial option in recording. Also, we cannot give. But you mentioned the age 18 years and 18 and a half and 19 years.
Because we cannot, sorry to, I mean, this is off. We cannot believe these police people also. So
No, see, madam, basically we are not there to judge the age. If
yes.
the patient says that she is 19 years, we should believe that she is 19 years. That's all.
Yeah, that is.
Yeah.
Hello. Just
Sir,
I wish
sir.
to add. I
Pardon,
wish
sir.
to add. Dr. Sampath Kumar is there.
Yeah, ma'am is there.
So now government is thinking of raising marriage of girl up to 21, and
That is very
havoc.
most havoc condition will
So
arise after that.
we all should oppose it. We all should oppose, not
Yes,
only
sir.
by doctors but our women's
Social,
organization also.
no, social organizations must
Social
do
organization
something.
must do something. Otherwise, that will be a havoc, and that will impact on our social life also. Because it's still 60% is a rural area. We are not telling, but if the people, no doubt, upliftment of women should be there. That should be the priority, but it doesn't mean that raising the age that will uplift the women's, and that is very wrong. That is very wrong. So if we will not oppose it, they may put up this in this session also. So Dr. Sampath Kumari, we are also thinking of opposing that bill of raising the women's age. So you also from your TNFOG should do it.
Yes, sir, we will do it. Here also in one of the medical college, Kanyakumari Medical College, what the judgment they have given is for failure of the sterilization, the government has to give 1.5 lakhs to the person.
Yes, I read that just 2 days
that also
before.
I told from TNF. Yes, Ajay.
Yeah, madam, that is wrong decision given by the High Court. I read that whole decision. Basically, the High Court are nowadays behaving like anything. That is wrong. In the document of the sterilization, which is given by Government of India and Government of Maharashtra, maybe Government of Tamil Nadu,
yes,
the failure is absolutely mentioned there. The failure is absolutely mentioned there. So it is not like that. It is not informed written consent. The failure is mentioned, then failure can be there. So for failure, 1.5 lakh compensation is never mentioned. For the complication, it is mentioned that as a 30,000 rupees or less, whatever the treatment needs. First thing. Second thing, if the MTP is needed, the MTP must be done free of cost. And any complication, it must be treated free of cost. That is mentioned in the law for the sterilization. But 1.5 lakh is never, and at no place it is mentioned that High Court has given.
Government Medical College case has been, I talked to that professor and she is telling we were not at all aware.
No, 100%. No, 100%, madam, they are going to acquit. No problem. Government will soon go to
Ajay,
Supreme
another
Court.
one thing, the person who did that case is no more.
Oh my God.
Oh.
How come?
But
I don't know the details. She told that she is not there.
Very bad thing. Very bad. But no, madam, that decision was very wrong. It is not mentioned in the law. The High Court cannot give such orders.
Anyway,
It will be acquitted in first
Supreme Court.
Yes, sir. I told them go for Supreme Court.
Supreme Court will squash it on first day only. It is not mentioned in law.
Okay, thank you.
Yes, ma'am. Yes.
Thank you, Dr. Sampath.
Yes, Chatra ma'am.
Vijayalakshmi, madam. Yeah.
Thank you, Sampath, madam. Thank you very much. Thank you, Pratibha, ma'am.
Thank you. Thank you.
Thank you.
One
Thank you.
of the pillar of TNFOG is Dr. Vijayalakshmi Jnanashekaran, treasurer.
Madam, Sampath, madam only.
As I mentioned, no, everybody is a great personality in today's webinar. Thank you very much.
Thank you, Pratibha.
Thank you, madam. Thank you for coming. Thank you.
Over to you, Vartika, ma'am.
Yes, thank you all dignitaries. Now moving on to our last session for today. This is on recent advances in preterm labor. And to chair this session, our first chairperson is Dr. Sarvana Kumar sir. Sir is Secretary, Obs-Gynae Society, Salem, Professor and Head, Annapurna Medical College and Consultant, Malan Maternity Hospital, Salem. Welcome, sir. And our second chairperson is Dr. Swati Rathod, Professor, CMC Vellore, She has many publications in international and national journals to her credit. Welcome, madam. I request Dr. Sarvana Kumar sir to introduce Dr. Pratibha Singh ma'am. Dr. Sarvana Kumar sir, please.
Hello. Hello.
Yes. Sir, you are audible.
Yes, sir, you are audible.
Yeah. Thank you for inviting us to this wonderful webinar. And I enjoyed
முடிச்சிட்டீங்களா?
முடிச்சிட்டேன் மேடம். அது
முடிச்சிட்டீங்களா? Okay, okay.
Completed the emergency. No, you have gone for
yes,
emergency.
Sir, I completed the emergency.
Great. This is our obstetrician's life. Very difficult.
Yes, sir. Ma'am, can I have the slide, please? Yeah, there is a lot of things to be talked about Dr. Pratibha Singh. She is well known to all of us. She is a consultant laparoscopic surgeon and IVF specialist, national coordinator of IAG FOXY, diploma in advanced gynec laparoscopy, and she is the past state honorary secretary general for 11 years, founder secretary of Society of Vaginal Surgeons of India. Madam, we need to ask you to come for one talk for us for our society also.
Yeah,
for
definitely.
the vaginal surgery.
Definitely.
Okay. And then organizing secretary for East Zone IMS conference. She has presented a lot of papers and contributed to the chapters. So her field of interest is high-risk pregnancy, endoscopy, and infertility. Over to you, madam.
Thank you, sir. Thank you for wonderful introduction. Can I share my screen?
Yes, ma'am.
Can you see my screen?
Yes, ma'am. Yes, ma'am.
Yeah, it is seen now, but not full screen.
This is not full screen?
No.
Ma'am, you need to stop share and share again.
Yeah. Now it is seen?
Yes.
Yes, ma'am. See, ma'am.
So, good evening to all of you and respected chairpersons and my dear friends. Now, before I start, let me give my regards to our chief guest, Dr. Sampath Kumari Madam and Dr. Rajan Singh Pardesi sir for accepting this invitation. And we just heard a very lucid talk by Dr. Ajay Manisher. So it was a wonderful talk, Dr. Ajay, and all the best for your future endeavors. And another talk by Dr. Kalpana was also wonderful. It was on ART and endometriosis. So thank you, Dr. Kalpana, for accepting this invitation. And I would like to thank all of you who had accepted this invitation on my behalf for this program. So thank you so much. And with this, I will start my talk today. And I'll be talking on recent advances in the management of preterm labor. Now, preterm labor is a leading cause of neonatal morbidity and mortality worldwide, and approximately 1 million deaths occur annually. And it is a major public health problem, we all know, mainly because of loss of life and because of long-term disability, like cerebral palsy, blindness, deafness, and CLDs. So this causes a lot of healthcare costs in both for the loss of the life, because for long the baby is in the ICU and a lot of financial burden comes on the parents, and finally they lose their baby. So that becomes a really emotional and financially they just break down for that. So that causes a lot of problems. Now in USA, preterm birth is 11.5% annually, and 75% is because of neonatal mortality, and 50% causes long-term neurological impairment in children. About 35 and 10% healthcare are spending on these infants and children. And the preterm birth in India is up to 15%. So in developing countries, they are unable to cope the costs. So that is why they have the higher neonatal mortality and morbidity in this class. Unfortunately, incidence of preterm labor has changed very little over past 40 years, and that is mainly because of the uncertainties which still persist regarding the best strategies for its management. So we have to have some recent advances in prediction, prevention, and the management of preterm labor. As far as you go for the definition of preterm labor, it is the presence of contraction of sufficient strength and the frequency to effective progressive effacement and the dilatation of the cervix between 20 to 37 weeks of gestation. This is the established definition of preterm labor. Now, preterm labor is often viewed as a result of decreased uterine stimulator coupled with the loss of mechanism that promote and maintain uterine relaxation. So there is a disbalance between the uterine stimulators and the uterine relaxation. And this results into preterm labor. And there are the three main components which contributes to this labor, that is cervical changes in the form of activation of deciduum and the membranes and the persistent uterine contraction. And it has been seen that there is difference between the labor at term and the preterm labor. The labor at term is usually they have come via normal physiological process, but the preterm labor is always pathological. And sometimes these processes are acute, but sometimes it can take several weeks also. Now, as far as incidence of preterm labor is concerned, it is around 6 to 15% overall. But the maximum type of preterm labor is spontaneous, which accounts for almost 50%. Because of PROM, it is around 25 to 40%. And because of obstetric intervention, it's 20 to 25%. Most mortality and morbidity is experienced by babies born before 34 weeks. Now, the question arises, can we predict preterm labor? So prediction has the key role in prevention of preterm labor, and the primary predictors known before the onset of pregnancy, whereas the secondary predictors are those which are detected after the onset of pregnancy. And the modifiable predictors are the malnutrition and anemia or whatever types where you can reverse it back, whereas non-modifiable predictors are like previous preterm labor who already had preterm labor, maybe she'll go again for that. So normally preterm labor can be predicted by assessment of the risk factors, vaginal examination to assess the cervical status, ultrasound visualization of the cervical length and dilatation, and finally the detection of the fetal fibronectin in cervicovaginal secretions. While the exact cause of preterm labor is often unknown, but there is a strong evidence that intrauterine infection plays a very important role in early preterm labor. And it is mainly because of the infection like the bacterial or the viral infection, which causes this preterm labor, maybe in the intrauterine or extrauterine both. And this PROM infection, they both lead to preterm labor. And it has been seen there is a disbalance between the synthesis of the protein component of the extracellular matrix and there is a degradation of the protein component of the extracellular matrix. And when this equilibrium is disturbed, it may result into infection and may lead to preterm labor. Now, risk factors like medical history, where patient has a previous history of preterm birth, or there was a previous history of any surgery on the cervix, or there was any injury during past delivery on the cervix or short cervix, or there was any early cervical dilatation which may result into the incompetence. Then other like factors like if the patient is, if the girl is very young, like less than 18 years, or advanced pregnancies. So in that case also there may be a chances of preterm labor, or pregnancy complications like twin pregnancy, polyhydramnios, or vaginal infections, vaginal bleeding during pregnancy. They all contribute to preterm labor. And also the lifestyle factors like low pregnancy weight, smoking during pregnancy, and dietary deficiencies. So finally, the vaginal examination, where you can do the digital examination, which is a traditional method to use to detect cervical maturation, but quantifying these changes is often, sometimes it is difficult. And there are few new methods which have come to assess the cervical ripening through the cervical collagen. And this cervical ripening precedes the cervical clinical symptoms. And these changes can be measured by two types of technologies, that is cervical resistance and light-induced fluorescence. These both causes, when they have been mapped and they are plotted on this, and then the ratio which comes with that, you can predict that there is cervical ripening and may predict preterm labor. Now, another is this fibronectin test. And we all know this is the basement membrane protein produced by fetal membrane and function as adhesion binder. It facilitates the attachment of the placenta and membrane to the uterine decidua, which is normally detachable in the cervical secretion, detectable in the cervical secretion until 16 to 20 weeks of gestation. And appearance of this fibronectin in cervical secretions after 24 weeks indicate disruption markers of inflammation of fetal membrane and decidua interface, which heralds onset of the preterm labor. So usually it is highly specific if it is negative and useful to rule out imminent preterm delivery. But if positive, then many times it is uncertain, and sometimes the sample collection is also an issue. Now there are we are getting certain kits also where you can take the secretions from the vagina and test for this fibronectin. So that is also available, but again, they are not very much efficient giving the preterm detection of or the prediction of the preterm labor. So it can be recommended in high-risk women who fulfill the criteria of intact membrane, minimum cervical dilatation of less than 3 centimeter, and gestational age between 24 to 34 weeks. Now, vaginal ultrasound, on which most of the time we rely. Vaginal ultrasound sonography allows a major objective approach to examine the cervix. Here, the cervix plays a dual role, as it holds the uterine content against gravity and maintains the intrauterine pressure until labor, and then it allows the passage of the uterine content during delivery. So cervical competency depends on the anatomical integrity and biochemical compositions of the cervix, and the earliest indication of cervical incompetency and onset of the labor is by shortening of the cervix. We all know it has normally been in the first trimester when we see, and when it has been reported like that, we should predict that there may be some chances of preterm labor. Then ultrasonography can also assess cervical length. If cervical length is less than 25 millimeter between 24 to 28 weeks, it is a high risk of preterm delivery. But again, there is a lot of variation in this. The person who is doing that test, sometimes there is a wrong way he is doing, and maybe that can cause a lot of problems for that. So there are a lot of variation in that. So what has come new is the real-time cervical elastography with the help of ultrasonography. And this is the elasticity image within a defined area of interest around the cervix, which is superimposed as an overlay of the B mode image. And it will be seen as a hard and the soft tissue at the level of the cervical os. And it can be identified at the softened cervix. So if you can see these images, on the left side is the elastography, and on the right side, it is the ultrasound images. So at the level of internal os, it is at between the 18 to 22 weeks of pregnancy. If the level of internal os, if it is soft, then the color will be red. And if it is medium soft, then it will be yellow. Whereas when it is hard, it will be blue. And when it is purple, it is the proper hard. So this way they are doing it, but it is very, very newer technique which has come now. And I think it is not still available all over India. In few centers, I think in Mumbai, it is available. And elastography is prediction of the preterm delivery in asymptomatic low-risk women. And this abnormalities can predict ultrasound and clinical findings such as cervical shortening and the funneling. So it can precede that findings. What we are finding when we come to know that there is a cervical shortening and funneling, before that we can come to know that there is some problem, and these patients may go into preterm labor. So that can be, this can be used as a predictor. But till then, the combination of fibronectin test and vaginal ultrasound is what we are doing, can be helpful. Like it suspect the preterm labor with no cervical changes. Like if there is a negative fetal fibronectin plus cervical length of more than 30 millimeter, it is likelihood to deliver in the next week is less than 1%. So such women, when we get such type of findings, then these women, we feel that they are safe and they can safely go at home, and you don't need to admit such patient, just that they can go into the preterm labor. Now, another newer modalities which can predict preterm labor is again that this genomic which is coming in big way. It is a gene array technology to identify candidate genes potentially involved in regulation of the human parturition. It was conducted that by detecting gene expression, it will be possible to predict preterm labor. And once you have predicted preterm labor, then maybe gene silencing can be the treatment of that problem. So that is the newer thing which has come. And again, there are, this is the new marker, which is the phosphorylated insulin-like growth factor 1, which is found in the residual tissue. And the process of labor disrupts choriodecidual interface, releasing PIG, FBP in the cervical secretion. And they mainly they are the indicative of the labor process and the predicts preterm labor. So if the concentration of this newer marker is less than 10 microgram per liter, then it is supposed to be negative, and these patients are asymptomatic and they have a low risk of preterm delivery. Whereas if the positivity is more than 10, then they are the positive, which indicate the preterm labor is imminent in these patients. And this implies at least 7 days in the hand they have during that. Now, so in spite of all these predictors, what we have to do is that if we can prevent preterm labor, that is better. And for prevention preterm labor, again, it can be broken into 3 categories, like reduction in the modifiable risk factors, broad-based prevention strategies, and the treatment of non-modifiable risk factors. If you can do that, then maybe you can prevent preterm labor and can be helpful for the patient. First and foremost, prevention. When we are predicting that, when we are thinking that this patient may go into labor, we will start saying that, okay, you go and take bed rest, which is very, very common. We all prescribe that, and we are all been doing that also. But the latest Cochrane review in 2010 says that there is no evidence either supporting or refuting the use of bed rest at home or in hospital to prevent preterm labor. Then what about the cerclage in those women who are at high risk of preterm birth? Again, the CIRCLE trial in 2009 says that the screening women at high risk with cervical ultrasound to determine cerclage placement results in more intervention, but similar outcome as compared with the history indicated placement. So there is not much difference in that. But although again in the Cochrane review in 2017, they found that the women with stitch are less likely to have a preterm baby. So inserting a stitch helps pregnant women who are at high risk avoid early birth as compared to no stitch. So you can very well try that. Then there are very little evidences regarding the use of other treatments like use of progesterones and all, but we'll be going one by one on that, how they prevent the preterm birth. So as far as treatment of preterm birth is concerned, there are lack of reliable and effective methods to predict and prevent preterm birth has resulted into very little change in the incidence of the preterm birth over 40 years. So often we face with a dilemma of managing an established preterm labor with variety of drugs which may have lack of uterine specificity, low efficacy, and potentially serious side effects of the mother and the fetus. As scientific evidences to use some drug is not very, very strong. Now, what about the role of antibiotics? Again, there is a lot of controversy regarding that, but the treatment of asymptomatic abnormal vaginal flora and bacterial vaginosis with oral clindamycin early in second trimester significantly reduces the rate of late miscarriage and spontaneous preterm labor. And what is this Cochrane review in 2010 says that the antibiotic prophylaxis, there was a reduction in risk of preterm delivery in pregnant women with a previous preterm birth who had bacterial vaginosis during the current pregnancy. But there was no reduction in the pregnant women with previous preterm birth without bacterial vaginosis during pregnancy. So this is equivocal. Now, what about progesterone? So prophylactic use of progesterone, either natural or synthetics, to prevent preterm labor reveals a significant decrease in preterm birth. However, it has not been successfully inhibited active preterm labor. So what is the proposed mechanism of action of progesterone in preterm labor prevention? It mainly inhibits the degradation of type 1 collagen in the cervix and immunomodulation and prevention of the decidual cell apoptosis. And also it mainly reduces or it mainly inhibits the contraction of the regulating gap junctions. Now there are evidences supporting the use of progesterone, and progesterone usually is associated with statistically significant reduction in the risk of preterm birth in women who have a past history of spontaneous preterm birth or threatened preterm birth. So this is the Cochrane review which has come in 2009. Finally, the trial done by Mears in 2003, they again reverted back with the role of 17-alpha-hydroxyprogesterone caproate, and that can, it can be used in the patient who have the spontaneous preterm birth. So 17-alpha-hydroxyprogesterone caproate has been in use for prevention of recurrent preterm birth since 2003, when this meso trial was published. And as a requirement, it has been approved by FDA, and it can be used for the spontaneous preterm labor. But the safety also demonstrates that it has a favorable safety profile as compared with the placebo. So it can be used in such patients. Vaginal progesterones, multicentric randomized controlled trials on vaginal progesterone gel to asymptomatic women with a singleton pregnancy in the sonographic short cervix, again has a remarkable reduction in the rate of preterm delivery. Now here they have interpreted by this evaluating progesterone by preventing preterm birth international collaboratives, and the interpretation was that vaginal progesterone and 17-alpha-hydroxyprogesterone caproate both reduces birth before 34 weeks gestation in high-risk singleton pregnancies. Given increased underlying risk, absolute risk reduction is greater for women who have a short cervix. Hence, treatment might be most useful for these women, but evidence for the oral progesterone is still insufficient to support this. Now, this is what we have been using since long, and is tocolysis better than no tocolysis for preterm birth? Again, the question is arising now. However, tocolysis should be considered, what we have been doing till now, that for few days again, so that we can buy some time to give corticosteroid to our patient, to the mother, or we can transfer the fetus in utero to the proper place where the delivery can be conducted, where all facilities are available. Now, what about the beta mimetics for inhibiting preterm labor? So this is the Cochrane latest review, came in 2010, which says that the beta mimetic decreases the number of women in preterm labor giving birth within 48 hours, but there was no decrease in number of birth within 7 days. So there is no benefit was demonstrated for beta mimetics on perinatal death. And also all the beta mimetics, including isoxaprine, retrodine, terbutaline, phenterol, though they are presently used by all of us, few of them we are using, but now it causes severe sympathetic side effects, and probably it is time for us to discard this now. What about calcium channel blockers? So this is the latest Cochrane review in 2011, which says that when tocolysis is indicated for the women in preterm labor, calcium channel blockers are preferable to other tocolytic agents as compared with mainly with beta mimetics. Then oxytocin receptor antagonist has been used for inhibiting preterm labor. So this is the Cochrane review in 2010, which says that the review failed to demonstrate the superiority of ertasobam over beta mimetics or placebo in terms of tocolytic efficiency or infant outcome. And oxytocin receptor antagonist, etosebon and nolesebon, this is the newer one which has been introduced now, which inhibits prostaglandin F2 alpha induced contraction and inflammatory response in the human myometrium. So according to RCOG recommends along with nifedipine as a first line agent in the management of preterm labor, and it is available as a solution. It can be given as a solution of 6.75 milligram or 0.9 milligram vial for the injection, and 37.5 milligram as 5 ml vial for infusion. IV slow bolus or infusion dose. Doses are IV bolus over 1 minute, followed by continuous IV infusion of 18 milligram per hour for 3 hours, and followed by 6 milligram per hour for maximum of 48 hours. And the maximum dose is 330 milligram per course for the maximum of 48 hours. But again, it is very, very costly. So it is not very much feasible in our country where we are practicing. Like I have it has come for almost for 5-6 years back now. And I think I have used in only one patient, and that also that patient could not complete the full course because it was really very costly. And but fortunately that patient with the minimum dose, she continued and we could finish the dose of corticosteroid, and we delivered the baby, and baby could survive in that case. So although I don't have much experience on this, but it is supposed to be the good for, but it should be affordable by the patient. Now, magnesium sulfate for preventing preterm birth in threatened preterm labor. Again, a non-significant reduction in the risk of cerebral palsy was reported as followed up 18 months corrected age. So it is also not used. Even prostaglandin synthetase inhibitor or nitric oxide donors are not effective, so not recommended. So there is insufficient evidence for any form of conclusion about whether or not maintenance tocolytic therapy following threatened preterm labor is worthwhile. Therefore, maintenance therapy cannot be recommended for routine practice. Corticosteroid, we all know we are giving just to for the lung maturity, and it should be given between 24 to 34 weeks. And the doses we all know, 2 doses of 12 milligrams of betamethasone given intramuscular 24 hours apart, or 4-6 milligram dose of dexamethasone given IM 12 hours apart. Finally, for the group B streptococcus prophylaxis, again, those patients, all patients in the preterm labor are considered at high risk for neonatal group B streptococcus sepsis. So they should be given prophylactic antibiotics regardless of the culture status. And the goal for this strategy is to prevent neonatal sepsis rather than to prevent preterm labor, preterm birth. So to conclude, even with all these researches and efforts, spontaneous preterm labor still remains an unsolved problem and a major challenge is in the 21st century. Whether newer biomarkers, genomics, or ultrasound elastography will be of help in early prediction is yet to know. Whether progesterone is a beacon of hope and calcium channel blocker, the real inhibitor, remains to be seen. So we should be we should not lose the track of the good history, because history taking, if you take a proper history, then you can prevent some non-modifiable risk factors, which will help to improve all the modifiable risk factors, and we can prevent some preterm labor to some extent. But until effective strategies are found, efforts should be aimed at preventing newborn complications by corticosteroid, antibiotics against group B streptococcus, avoiding traumatic deliveries, delivery in the center with experienced resuscitation team, and neonatal intensive care. So that should be done. And the future is on these microbiomes, which influences the risk of preterm birth. So in our bodies, there are trillions of bacteria and virus and fungus. And these taming population is known as the microbiomes. And they are, and the scientists have learned over the last 2 decades, the microbiomes can influence our body, how the microbiomes can affect our body and how it works. So there was this human microbiome project which is going on, which identifies these strains for the prevention of these different type of diseases, like studies on the vaginal microbiomes. This has been done as a researcher work by Dr. Jennifer and Dr. Buck from Virginia, and they studied that the vaginal microbiomes can change during pregnancy. And they also measured how such shifts correlate with the risk of preterm birth. They examined the microbiomes in the samples collected over time for more than 1,500 women for a diverse population. And then they did the study, and the result was published in May 29, 2019 in Nature Medicine. And they found that these vaginal microbiomes, they have different type of either harmful microbiomes and the good bacteria. So, and you can identify both of them. So like in this, if you can see, this is Lactobacillus Christopus, which is supposed to be the good bacteria, and the Lactobacillus deniseri is again the good, but the Gasseri and Isoranine are the harmful bacteria. So if you map on the, if you plot on the chart, you will see that those, if you can see the down one photo, the person who has a low risk, they will be having a clean sheet. Whereas those who have pre-ORM, those where there's infection is there, they have this dirty type of screen will be seen. So this way you can find out about this prediction of the preterm labor. So this is the new hope, that now the use of microbiome data coupled with the clinical and other observation to develop a predictive model for preterm birth that will allow us to more accurately identify women who are at high risk for early pregnancy. It may be possible to develop a test for vaginal microbiomes that could guide intervention to reduce the risk of preterm birth. So till then, we have to rely on what we are doing, but these are the new hopes or new discoveries which are coming, which may help us to predict preterm labor, and we can prevent such preterm births. Thank you for the patient hearing.
Thank you, ma'am. I request Dr. Swati Rathod, ma'am, to say a few words. Dr. Swati,
Yes.
madam.
Yeah. Thank you, Dr. Pratibha, and thank you all of the team. Dr. Pratibha, it was a very nice presentation. It was very good. And definitely it's one of the leading causes of the neonatal morbidity and mortality, the preterm labor. And you have done a very good job, and beautifully you have presented on the use of the elastography, the fibronectin, the use, and the gene expression, expression for the predicting the preterm labor, and the management, the both vaginal progesterone and the injectable progesterone, and the use of the tocolysis, and the newer drugs, the etoxapain and all also, and the future things, which is about the microwork. So it's a very nice presentation, and I thank all of the team for conducting this very good webinar. And this is definitely, it was a mixed bag with continuing with the medical legal, with the endometriosis, and all of the about the recent advances in the preterm. So thank you very much. It was a very nice.
Thank you, madam. And it was really, I really want to thank everybody who joined today. And it was all our chairpersons, our speakers, everything. I want to thank all of them. And yeah,
ma'am, may we have 2 minutes for the shield people?
Yeah.
They want to.
Yes. Kindly play the video, please. We can have question answer session after that. great. All great products from Shield Healthcare. Thank you.
Thank you very much for
Thank
this
you, Dr.
opportunity.
Stalin. Yeah,
Thank
it
you.
was very nice. I'm using 2-3 of them. They are very nice. Okay. Just I wanted to ask Pratibha Singh ma'am. I have heard a few lectures from the medical colleges that they are, as on today, using the progesterone as a replacement for cervical encirclement. How true is it?
Ma'am,
you are muted. Because see, mechanical causes may not be treated by progesterone, I think.
Yeah.
What is the truth nowadays?
No, that is in the second trimester if there is a cervical incompetence. If you are seeing in the, ultrasound has shown that the length is shortening and cervix is short, in that cases, you can give cervical cerclage. But 17-hydroxy progesterone caprate can be used for the spontaneous cases of preterm labor. That is what we are using.
Okay, it cannot be replacement for the cervical encirclement, no?
No. That is
some of them have claimed that no, nowadays we have forgotten the cervical encirclement, we are using only progesterone, which is, I don't think what the senior persons from Tamil Nadu says.
Anybody can comment on that. Dr.
Sarvana Kumar sir, what is your experience says, or what is your practical things? Sir, you are muted. Yeah.
Sir, I didn't get the question. It's very low here.
Hello.
Just a minute.
No. What is your opinion regarding the use of progesterone and?
Hello.
Madam,
am I audible now?
Yeah.
Madam, can I have the question please again?
Yeah. Actually, Dr. Ajay Manisher is asking that what is your opinion regarding the use of progesterone and the cerclage? Whether cerclage will replace, we can use progesterone and can replace cerclage stitch.
No, ma'am. I am still the old school. I still prefer to put a cerclage for the patient.
I'm also in the favor of cerclage in certain situations, but some of the medical college people, they are saying no, you are old fashioned. Nowadays we are using only progesterone instead of cervical cerclage. We have forgotten that. Likewise, well, sir, I could not get the data, so I asked, you are stalwart and you are working in a very large population. So what is your experience likewise?
We put a cerclage, sir, but if it is when we think that it is probably can be progress, because if it is not that is historical previous preterm labor or this one, and the cervical cell length is less if it is given in the scan, then we put a progesterone.
Yeah, see, basically 25 millimeter is our threshold, but for 18 is our lowermost border.
Yeah, lowermost.
If it is less than 18, we need to have a stitch, basically.
Yeah.
Okay.
That's what I suppose.
Yes, sir. But suppose if the patient has got a previous abortions or a preterm labor, then probably even with a smaller, with a 25 millimeter, I put a cerclage rather than this one, progesterone.
Yeah.
Yes, sir.
What is your opinion regarding putting cerclage in all the cases of twin pregnancy or triplet?
No, madam,
okay, preventive cerclage you are asking about.
Yeah.
No, madam, not on all cases.
We are not using it. Okay.
It is selective only, madam.
Yeah, selective.
That's what I also said. It must be selective.
Yeah.
It is not likewise a rule for all.
For all twins, yeah.
Like they have come that with 17-hydroxy progesterone caprate, you can use it. It can replace. It has come in so many journals now. But
that's what I'm worried about.
Green Top guidelines still gives progesterones for this one. But still we are using a stitch only.
That is this thing. I have my experience.
Yeah, in certain situations, we cannot take risk.
Yeah, that is true.
Though the guidelines are there, depending upon the situation, we can decide whether to use. What, Swati madam, what is your
I will ask Dr. Swati. Swati madam, what is your opinion?
Yeah, so for the prophylactic cerclage, we are not doing, like for the twins and the IVF pregnancy and the triplets, it's not indicated.
Yes.
Only the history indicated, or if the cervical length is shorter, like as you said, well, like 1.7, 1.8 millimeter, then we are putting the cerclage. And about the progesterone, the vaginal progesterone or the oral progesterone we are giving, injection Proliton, that is the hydroxyprogesterone, weekly, it is, but still the vaginal progesterone, it is better than the injectable.
Yeah.
What is the newer guideline it says. And so we are using that, like our protocols, we are following
What
that.
are the indications where you are using this vaginal progesterones? In all cases or?
Like, no. If it is like a previous history of 2 or 3 abortions, which was confirmed, and like more than 12 to 20 weeks during that, we are giving. Or if the IVF pregnancy is there, then we are giving the progesterone for them. But cerclage, we are not giving. And that is also till 20 weeks, and then we'll stop.
No, if the cervix is short, then we are putting cerclage. That is what this thing.
Yeah. Yes. So if cervical stitch is put only when definitely there is a cervix is short.
Yeah, only means for mechanical reason we are using cervical cerclage.
Yes,
for
definitely.
mechanical reason.
Yeah.
Yes. Okay. Right. Thank you, madam. Thank you very much.
Thanks.
Yeah. Over to you, Vartika, ma'am.
Thank you, sir. So after this wonderful session, I would like to thank for today's session our chief guest, Dr. Sampath Kumari Madam, and guest of honor, Dr. Rajendra Pardesi sir. Our esteemed chairpersons, Dr. Jyoti Madam, Dr. Saroja Madam, Dr. Vijay Lakshmi Madam, Dr. Chandra Madam, Dr. Sarvana Kumar sir, Dr. Swati Ma'am, and our learned speakers, Dr. Kalpana Madam, Dr. Ajay Manisher sir, and Dr. Pratibha Singh Madam, and Dr. Stalin and Shield Healthcare to give all the technical support. Thank you all for making this webinar a great success.
And I want to thank Vartika for conducting this session so well. In spite of she is so busy in the marriage, but still she came. Thank you so much. Thank you.
Oh, thank you, Vartika, ma'am. Thank you for the gesture. And thank you. And thank you, Stalin, sir.
Thank you, ma'am. Thank you, sir. Thank you very much, sir.
Thank you very much.
Okay, bye.
Yeah. Thank you, Sampath, madam.
Okay.
She is there still.
Yeah, she's there.
Till the end. Okay.
Okay,
sir.
Thank you, Ajay.
Thank you, madam. We need your
Thank you,
blessing.
madam. Thank you, madam.
All the best. All the best.
Madam, thank you.
In person, both of you come to Chennai. See you.
100%. 100%.
Definitely.
Stalin will sponsor.
All the best.
Sure, ma'am.
I'll be coming for third time. Yeah. Two times I came there.
Okay, nice. All the
This
best.
time I'll come to your house, madam.
Sure, definitely. Both of you. Last time itself I called Ajay.
Yeah.
But that was not time. Both of you come to my house and